Assalamualaikum, welcome to today's CME with me, Syafiqah Saharudin, speech therapist, Hospital Sungai Buloh. For today, we will be learning and refreshing our knowledge on swallowing. Thus the title, Back to Basic, with swallowing, refresh, relearn and re-energize. In today's CME, I will be focusing on these three main questions. What is the normal swallowing skill? In order for us to treat and manage patients with dysphagia, we need to familiarize ourselves with the normal set of swallowing skill. What is the muscle and cranial nerve involved? Then we need to understand what is dysphagia itself. Next is, how does normal swallowing happen, especially in the phases of swallowing? Then we can compare it with dysphagic patient. Lastly, when do we need to refer this patient with swallowing difficulties to speech therapist for swallowing assessment? Then we come again to the question, what is swallowing? I will let you a minute to think and juggle back your memory. What do you feel swallowing is? Swallowing by definition is a process of degglutination of food and water, including biting and chewing, that involve a complex neurophysiological task of 26 pairs of muscle and 5 cranial nerve, which is trigeminal, facial, glossopharyngeal, vagus, and hypoglossal, which involve both voluntary and involuntary muscle contraction. For trigeminal nerve, it involves in the control muscle of biting and chewing, facial sensation, assist upwards or anterior larynx movement, backward tongue movement to soft palate, tensing of soft palate, posterior pharyngeal wall constriction. For facial nerve, it involves in the taste sensation two-thirds of the tongue and also muscle control. For example, circular muscle of the lip for lip closure and keep the food or liquid inside. Next is the glossopharyngeal nerve. It involves in a one-third taste sensation of the tongue and it relays sensory input to tongue, pharynx and soft palate, and also involved in salivation. For vagus nerve, it controls the sensation of larynx, back of tongue, pharynx, palate and its muscle. Lastly, for hypoglossal nerve, it controls the tongue. These cranial nerves play a very important role in swallowing. Once we already know what swallowing involves in, we need to know what is dysphagia. As you can see here, when a person eats in a fast manner and in one go, it will lead to choking, as seen here. Same goes when a person drinks water, as shown in the picture. This will lead to coughing or choking or other aspiration symptoms. Dysphagia, by definition, is a swallowing disorder involving the oral cavity, pharynx, esophagus or gastroesophageal junction. Other definitions would be an abnormal delay in transit of liquid and food, which may cause pain or discomfort during the passage of liquid or food while entering the stomach. As shown here is the number of cases speech therapy hospital Sungai Buloh had attended throughout the years. In 2018, we had seen around 994 cases, 2019 1,131 cases, and a definite drop to 2020 449 cases, and 2021 153 cases. The drop in 2020 to 2021 is due to COVID-19. And as shown here is the number of cases of speech therapists throughout Malaysia in KKM had seen dysphagia cases. In 2018, we had seen 18,043 cases, 2019, 21,024 cases, and 2020, 19,331 cases. This number alone show that dysphagia cases is one of the main cases that had been referred to speech therapists to manage. Next, we have come to our next question. How many Fs is there in swallowing? Is it 2, 3, 4 or 5? I would like you to take a guess. That's right, there is 4 phases in swallowing. As shown in the barium swallow here, it only shows 3 phases. Can you identify these 3 phases? Swallowing started with pre-oral or oral preparatory phase. Next is oral phase, followed by pharyngeal phase, and lastly, esophageal phase. In pre-oral, I will give you a set of images. For example, nasi lemak, satay, tom yum, laksa Penang, and chendol. How do you feel when you see these images? Have you guys started salivating yet? In pre-oral phase, there is a parameters that include physiological effects that occur when one anticipates food and first smells or sees the food. The peripheral sensory inputs of vision and olfaction are integrated and processed in the orbitofrontal cortex. The anticipation of food can initiate physiological processes that support swallowing. For example, the salivary reflex in the submandibular gland is stimulated when odor stimulus is presented. That is why the presentation and the smell of the food plays an important role for us started to swallow. Next is oral phase. There are a few biomechanical processes that occur in oral phase, which is labial closure, lingual control, glossopalatal closure, and buccinator press. Let's see these processes one by one. When the food first enters the oral cavity, the tongue is grooved in the midline to accept it. Once the food is in the mouth, the labial seal is maintained to prevent anterior spillage. As the tongue grooves in the midline to accept the food, the bolus is held in the mouth between the tongue and anterior palate and the lateral part of the tongue against the alveolus. The velum during this stage is pulled downward and seals the oral cavity by making contact with the elevated back of the tongue. With the bolus now on the tongue elevates in the midline to transfer the bolus laterally within the posterior teeth of mastication. At this point, the buccal musculature holds the bolus within the oral cavity laterally, and glossopalatal closure prevents premature spillage into the pharynx posteriorly. Solid food is masticated to reduce its particle size. The sensory information from the bolus, such as texture, volume, temperature, and chemical composition, plays a role in mastication by continually sending feedback to the central pattern generator for mastication. The onset of swallowing signifies the end of oral phase and the start of pharyngeal phase. In pharyngeal phase, it consists of number of biomechanical activities which occur simultaneously. It includes 6 biomechanical activities, which is hyolaryngeal excursion, which deflects the epiglottis, velopharyngeal closure, base of tongue to posterior pharyngeal wall approximation, pharyngeal peristalsis and shortening, elevation and closure of larynx to protect the airway, and relaxation of upper esophageal sphincter or UES. The pharyngeal swallow is an all or none reflex. At the end of oral phase, there will be a drop of the tongue base and push from the tongue blade to propel the bolus into the pharynx. With this simultaneous tongue movement, the deep muscle receptor at the base of the tongue will be activated and paired with superficial sensory and cortical input will elicit the swallowing reflex, signifying the start of pharyngeal phase of swallowing. Cortical input from the limbic system, frontal lobe, basal ganglia, and other areas associated with feeding. The hyolaryngeal excursion is in the superior and anterior direction, accomplished primarily by contraction of the suprahyoid and strap muscles. Other name is infrahyoid muscles. During anterior hyoid movement, the epiglottis is deflected to cover the laryngeal vestibule and traction force will be applied to pull open the cricopharyngeal muscle or UES. During pharyngeal phase of swallowing, velopharyngeal closure is achieved by elevation and retraction of the velum. The velopharyngeal port is completely closed to prevent bolus from entering the nasal cavity or nasal regurgitation. Swallowing is a pressure-driven process. The base of tongue and posterior pharyngeal wall must approximate to provide the initial positive pressure to push the bolus through the pharyngeal lumen. This continues from the drop and push event of the base of tongue to elicit the swallowing reflex. It also assists with epiglottis deflection. Pharyngeal peristalsis via contraction of the pharyngeal constrictor is utilized to clear small boluses from the pharynx. During contraction of the pharyngeal constrictors, the pharyngeal cavity is shortened and the UES is brought superiorly to accept the approaching bolus. The airway is protected during swallowing by epiglottic deflection, which is mainly achieved by anterior hyolaryngeal excursion. The superior and anterior displacement of larynx will keep the larynx under the base of the tongue, away from the ingested material. Further laryngeal protection to prevent penetration and aspiration is also in place. For example, closure of the true and false vocal folds. The last phase in swallowing is esophageal phase. Once the bolus is in the esophagus, we are now in the esophageal phase, which starts when the bolus is transported through the UES. It is carried towards the stomach via esophageal peristalsis. There are two types of peristalsis, which is primary and secondary. Primary peristalsis is the continuous peristalsis of the pharyngeal muscles which pushes the bolus through the UES. The waves of peristalsis is now in the esophagus. Therefore, primary peristalsis is still under the control of swallowing center in the brainstem. When the primary peristalsis is not able to move the bolus through the esophagus, secondary peristalsis will be initiated. This is triggered by distension of the esophageal wall caused by the bolus in the esophagus. Thus, secondary peristalsis starts at the site of distension and moves towards the stomach. Once we already know the phases in swallowing, we need to know why does dysphagia happen. The most common reason of dysphagia is stroke, traumatic brain injury, dementia, cancer, and currently prolonged intubation that we had seen in COVID patients. What is the sign and symptom that occur when someone has swallowing difficulty? One of it is coughing, choking, or if the person does not cough or choke, we need to see the shortness of breath or prolonged fever. In silent aspiration, usually patient will exhibit shortness of breath or high-grade fever. Another sign and symptom that somehow being missed by us is excessive drooling, delay and multiple swallow. For example, in this picture, the patient having a longer time in swallowing thinned liquid or blended food. Next is pain during swallow and also voice changes. For voice changes, we need to know the difference between normal voice and breathy or gurgly voice. What should we see or assess first before we refer patients to speech therapists? First, we need to see the medical diagnosis, and also is the patient on tracheostomy or ventilator. For patient with ventilator, especially on ventimask, speech therapist does not assess the swallowing first. We need the patient to wind down to nasal prong, then we can do the swallowing assessment. For tracheostomy, we need to know if the patient on cuff or uncuffed tracheostomy, then we can do the swallowing assessment. Next is the alertness. How much is the GCS? Can the patient obey simple command? This is important before we refer patient to speech therapist for swallowing assessment. If the patient alertness is low, speech therapist cannot do assessment to the patient, as we need patient to be aware that they need to swallow, they need to receive the food, and they need to chew and bite the food or liquid. Next is the speech and voice. We need to know if the patient voice is it wet or is it breathy. If there is a sign of breathiness in the voice, we need to rule out if the patient have vocal cord palsy or paresis. Usually this kind of voice we can see for prolonged intubation patient or patient just extubated, and we need to assess the voice first. And then other signs like drooling, weak cough and secretion. For drooling, we can know that this patient might have problem in controlling his or her labial closure, lingual control. Also for weak cough, probably the pharyngeal sensation and secretion that patient cannot manage the secret inside once oral cavity. Then when you already assess all of these criteria, if the patients achieve the good criteria for assessment, then you can refer this patient to us. This is our extension. For Puan Rosila and Puan Ashikin, it is 1106, and for Puan Azlin and myself, it is 1109. This is my references. And if you have any question regarding swallowing, you can just knock on our door and we gladly help you in managing the cases together. Thank you, and I hope for assessment and management for swallowing cases, we can see you on the next CME.